There's a few things I want to talk about and make sure I cover as far as ethical stances. Basically, one of the things that we have to remember, and this is kind of building on the material that we've already heard, is that both you as the therapist and the client have grown up and experienced life through that heteronormative standard and have built heterosexist lenses. Normality and the thought of normality, that's why I was using those terms mindfully earlier about what's normal or what feels abnormal to a person. We have to be mindful about that because we have notions of what normality is, and we certainly, in the culture of psychology, use things like statistical averages to develop normality. I mean, we love the bell curve in mental health. We love looking at what falls in that window and actually deciding what's pathological using normative standards. One of the things to be mindful of is that we really have moved from this stance of thinking of being gay as unhealthy or ill to a stance of this is a variant of normal sexuality. And so even though it may not fit the statistical averages, that it's still within this larger continuum of the bell curve of possible expression of one's sexual self. And I keep focusing on sexuality, and I want to make sure that I expand that because this is, of course, bigger than the sexual self and self-concept, because relationships for gay men isn't just about sex. I think that's one of the biases, one of the stereotypes that we kind of go with, that this is about sexuality. I think this is one of the reasons that we if we use the term homosexuality, we use it mindfully. We use it when we're dialoguing about different branches of sexual orientation. But getting out of that, you have to remember that these relationships are built of attractions that aren't just sexual. These relationships between gay men, be they sexual or social, they're relational at their best, and that includes emotional, it includes physiological, it includes spiritual components. And so we have to give this a fullness of understanding and not just lump it once again into these sort of statistical norms of what we expect. Once again, we think about the terms homophobia and internalized homophobia when we're working with our clients and how that impacts them. We'll have clients that want you to fix things. We kind of love that term in mental health, and I mean that sarcastically, because people come in to be fixed. And really, we're working to not treat people like they're broken objects. We're really looking to see, what's functional. I certainly work from a standpoint that looks at ego strength and looks at what's working and what could work better. What isn't working and why? Where did that develop and where does it come from? We know that when we're working with gay men, we have to be mindful of things like internalized homophobia and that heterosexist lens, and how that can create actually cycles of shame, how it can disrupt relationships, how it can create self-deprecating natures, how it can actually even create overcompensation because of internalized shame. We're very mindful of those pieces for sure. And so we also need to be mindful of the biases that have existed in clinical research and training. I know that one of the more famous stories about homosexuality being removed from the DSM in 1973 was, there were clinicians using science, both sides, able to show through statistical averages and results and using the scientific method and through good research, finding research to prove their side. And we have to be mindful that even the research can come from a heteronormative lens. If the bar is that heterosexual behaviors are normative, then the research is going to be guided by that inherent bias. And we have to be mindful of that. And certainly in our training, when we're training clinicians, how often in programs do you actually include training on the LGBT population versus just a generic or general training on cultural diversity and cultural competency? And not that those things are bad, But we're talking about some very unique and specific areas that are important to learn, which is why we're presenting these advanced areas of study and working with the LGBT community and specific segments of the LGBT community. So we need to be mindful of also too, and I think about that term LGBT as umbrella terms and how often we use umbrella terms even in psychology to simplify things. And so when we say this is the person that fits the G in the LGBT, the gay men of the LGBT, that doesn't tell us anything about all the subgroups and all the diversity and all of the different areas of that an individual person may align with or actually resist that's part of the gay male culture, and how they respond to the dominant culture. So what you're going to find in the PowerPoint that's associated here is basically I've included some of the APA ethical guidelines, some of the codes that they talk about, and once again the link for the guidelines is there if you need it. And so there has been currently a committee that's been working on trans issues and guidelines, and that's been building over time. We'll focus on really gay men specifically here and understanding the impacts and the dynamics that are important ethically for us to be mindful of in working with gay men and what's happened in their lives so that we can tailor our treatment planning and our work. So we want to understand, one of the things we need to be mindful of is, first of all, we have to look at our bias about is homosexuality an illness? Sexual orientation, once again using that word homosexuality mindfully here. Is my gay client sick because he's gay? And if we have that notion, what do we do with that? Should we be working with this person? And certainly what we're finding from an ethical standpoint, we should not, or we should be seeking consultation and direction when we have those sorts of biases there. And certainly there are whole groups of people in the mental health community that practice things such as reparative therapy and conversion therapy, and I've heard some new terms like gender affirmative therapy, which certainly take this notion that homosexuality and bisexuality are forms of mental illness. And that is not something supported by the APA ethics, and certainly as we go through and look at other ethics, you're going to find that this is true amongst most, if not all, governing bodies, national governing bodies that govern mental health ethical codes and regulation. So we also have to understand the impact of social stigmatization on the well-being of LGBT clients. We want to be knowledgeable about LGBT relationships. We want to be knowledgeable about the relationship for gay men. What does that mean? What are the challenges? What are the challenges specific to gay parents? What is the effect of those challenges? What is the impact on one's sexual orientation? And what is the impact of that sexual orientation on one's family of origin and their familial relationships? So one of the things that we want to be mindful of is we need to think about the unique challenges experienced by that intersectional components, the intersectionality of when we're including things like racial and ethnic minorities, when you're dealing with someone who is a gay youth, our gay elders, including intergenerational issues and how generations relate to each other, the generations of gay men in the gay male culture. How things like physical, sensory, and cognitive or emotional disabilities might impact gay men that you're working with. And all of these, and how do they come together to create the person that you're working with, and how do they impact that person? It's really that mindset of thinking, we're not in this continuum, we're not in this one area, we're really this amalgamation of different things that make up the self. We need to consider and understand issues such as workplace dynamics, and we need to be doing this. We need to be mindful of the training that we really need in the education. And part of why I do this is part of the way I advocate. This is part of the way that I give back to the LGBT community, and certainly the gay male community, is by doing trainings like this so that good work can be done for the gay men out there. So some general things to be thinking about as far as ethical codes. Once again, just some general ideas in the APA ethics are things like do no harm. And I kind of like the notion of if you can't do any good, at least do no harm. And if you can't do any good, refer them to someone who can. You know, we conduct our work. The psychologists that are watching this know that this is part of the APA ethics codes and certainly part of my work as a psychologist, that we work from a place of respect, we work from a place of dignity, and we fight and advocate for justice for all people. We work to have cultural awareness and maintain our cultural knowledge. We work towards understanding the effects of prejudice, oppression, discrimination, and how that impacts people of all minorities. And we certainly look for evidence-based practices in treating the gay men that we treat. And once again, you're going to find groups that say that they're practicing from evidence-based practices. They're practicing from culturally aware practices. One of the big arguments that I've heard, and here's my bias against this, here's my disdain with this, because it feels like we're trying to create truth where there is none. Being that is certainly my bias here. The argument being, well, if I'm really a culturally aware therapist and they ask me to fix them, fix their homosexuality, fix their gayness, then wouldn't a good culturally aware therapist do such a thing? And here's the truth, is that statistically, when we look at the results of reparative therapy, is that even in the studies that support that, you see that about 2/3 of the population do not receive benefits from that process, and that's usually waved away. Well, they didn't really want it. I think that's an interesting sort of notion to say that. And also, we also see that a lot of persons who undergo things like reparative therapy and conversion therapy, trying to make someone an ex-gay, actually has led to increased likelihood of suicidality, depression, increased pathology, increased lack of health. And so we don't engage in those practices when we work from an ethical practice, not when we're looking at the guidelines from, most guidelines from our regulatory committees that regulate mental health.